I want to welcome folks. As you're joining, we're waiting for other people to get into the waiting room.
Oh,
and we will start at
it's working.
4 o'clock sharp.
Never mind. Sounds good. Here. Oh, how do I move? Mute. I want to mute.
It's down at the bottom of your screen on the left. They're definitely getting some feedback. Please mute, guys, so that we don't hear that crazy speaker sound.
Into repairs has to get
We'll give it one more minute while people are calling in. Okay, well, I have 4 o'clock Eastern time, so we will get started. Welcome everybody to the next in our series. We're into our 4th week of Huddle calls. And my name is Margie Beaudry. On behalf of Trust for America's Health, I'm very pleased to welcome you again to our discussions about challenges and solutions for ensuring access to COVID-19 vaccines for older adults and people with disabilities who cannot leave their homes. This session is being recorded so we can capture all the ideas and experiences shared. This call series is part of an initiative to identify and foster adoption of innovative and promising practices on this topic.
Go to sleep.
Ask again if people could please mute their lines. This work is made possible through the generous support of the John A. Hartford Foundation, which works tirelessly to improve care for older adults, and the Cambia Foundation, dedicated to improving the way people experience health care. Having a little trouble. There we go. So access to the COVID-19 vaccine for older adults is being prioritized across the country due to the vulnerability to more serious illness from the virus among this population. However, for the estimated 15 million older adults and individuals with disabilities who do not leave their homes, access is challenging or impossible. These challenges are not well understood, but government agencies are beginning to attend to these challenges as the vaccine supply increases. State and local health departments across the country, working in partnership with the Aging Network, hospital systems, and other community partners, are turning their attention to this population, and a variety of innovative and practical solutions are emerging. We're all learning together at this critical moment in time. These huddle calls are designed to share just-in-time or just learned information as broadly as possible. In studying this topic, we are seeing some themes emerge. Of course, and over the course of this call series, we are trying to touch on each of these themes from various perspectives. This graphic depicts these themes as separate ideas. However, in practice, they are interwoven and interdependent. A change in resources or implementation strategies in one area has a ripple effect throughout the system. For example, if the method of identifying the population of people who are homebound leads to a larger or more diverse pool of those in need, it has practical implications for the resources needed to meet that need and the distribution partnerships and types of messaging required to support the effort. Based on key informant interviews, literature, and social media, and expert discussions, TIFA is developing a policy brief to help support actions to address the challenges. Today's huddle call is devoted to considering a few of these recommendations that have been drafted for that policy brief. And with that, we're going to put our first recommendation up on the screen, and we'll look at it together. And invite you all to start discussions. We're doing things a little differently today, as you can see. So this recommendation relates to expanding the pool of vaccinators. Governmental and non-governmental organizations scheduling home vaccinations should ensure that whenever feasible, the vaccination team includes people who represent the diversity of the population being served based on local cultural, disability, and linguistic needs. And here we have posed some questions for you all based on your experience, what's happening on the ground, and how you are addressing this challenge. Will there be enough capacity? Will there be a capacity issue with this recommendation? Will there be enough qualified people to meet the requirement? And should this apply to home care provider agencies as well? Will this pose a resource challenge? So with that, I'll open it up for discussion. We are happy to have people put their hands up in the chat, or put their hands up in the participant list, or if you'd like to put a question in the chat, that is fine as well.
Margie, this is Megan, and I'll kind of start off the conversation here a little bit today. I mean, this is so we know that to develop trust with older adults and people with disabilities who are at home, who may be, have diverse backgrounds in terms of culture, language, and ethnicity, that sometimes it is, they need to know that someone understands them. They want to see someone with the same skin color or that have the same language who comes into their home. And we know that that's important, but I recall from my time when I was in education, when we were talking about imposing greater requirements for like physical education teachers, we wondered, well, gosh, if we raise the bar, will there be enough people who are qualified to meet that bar? So I think that's what kind of comes to mind for me, and just in terms of talking about this issue. Will there be enough people who can, become vaccinators who will meet this recommendation? So that's kind of where I'm coming from. I'm interested to hear others' input.
I just jump right in on that. I'm Mary Jo, and I'm with the Research Family Foundation in Oregon. And what we're doing is we've partnered with Medical Teams International. They have dental vans. It's an organization that has dental vans, and they're taking those dental vans out to rural communities and out to farm laborers, and then they partner with local, either might be a faith-based organization, might be a community-based organization, wherever the level of trust is, with the local folks there for seniors, for folks in these migrant labor camps, to get the vaccines out that way, using local people who already have the trust established. But the dental vans will have the staff on that can give the vaccines. And right now we're in the process, we're helping to fund it, but we have the contracts are sitting on the desk, but we're just waiting to confirm that we have access to the vaccines. And we're ready to start with 6 teams here in Oregon to reach vulnerable, underserved communities throughout Oregon. So that's how we're approaching it. I'm looking for partners, of course, too, along the way.
This is Erin with the Idaho Commission on Aging. And of course, Idaho is a primarily rural state, only a couple of population centers and not large by anybody's standards. We are doing a couple of things. First, we worked with our Department of Health and Welfare just last week to put out a flyer, double-sided, addressing particularly vaccine hesitancy by seniors, telling them, this is where you go to register, and Idaho has a single registration point to pre-register, and then they're notified when it's time, but also addressing some of their other concerns, such as there is no cost. If you have insurance, your insurance might be charged, but you will never be charged. Some of the reactions, and also transportation that our AAAs are able to provide For those that are homebound, we have been trying to work with our community paramedics and fire departments who have the capacity and ability to go out and serve some of the people that are homebound without making them leave their homes and get to an immunization center.
Fascinating. We have a couple comments, questions and comments coming up in the chat. So I'll share a short one from Kathy Cubitt. Great question. Kathy agrees with the recommendation, but wonders how this will be measured or tracked. How will we know if we're succeeding at doing this? And it goes to a question that has come up a lot about anything related to the tracking and the measurement of success on these innovative practices. Is anybody working on this, and how are you tracking this sort of thing?
This is Erin again. And real quickly, of course, we have records with our paramedics and fire departments when they service people that are homebound. So that's a pretty easy one. Otherwise, it can be challenging.
Mm-hmm. Dennis, and before we move on, I'll just say, Kathy, the question you're raising about measurement is one that has come up a lot in our discussions and in our interviews, and I think it will loom large in the policy brief as well. So there's a question from Dennis Heafy, but Dennis, I think you have a decent amount of detail here. I might invite you to just unmute and share your question. And we're not hearing you, so I will attempt to read it here. So Dennis says there are people who are situationally homebound because they are medically complex. Under normal circumstances, these people might, get a vaccine access in the community, but due to the high risk of illness from COVID, they cannot do that, and many would say they should not leave their homes. So how does this population fit into an understanding of the homebound? This is really goes to the question of how one defines homebound, which is a whole nother theme area related to this work. But it's still a great question, because obviously if those people need to have vaccines in the home, it definitely changes the volume and the demand here. What do others think about including folks who are medically complex in the definition of homebound, and how might you deal with such a group?
I mean, I think that you have to consider that the medically complex are part of, I mean, it's like if their complexity requires them to stay at home, then of course they would be considered part of this population. But I think it does go to address the complexity of just identifying who the population is. And so I wanted to go back, if I could, and ask a question of Mary Jo. Mary Jo, with your dental vans, have you already identified the population that are homebound because they are served by the vans?
Yeah, I think MTI is working on that and trying to figure out how they can access people. I mean, what they've been doing it in Washington, but that's been more with the migrant population in agricultural workers, and not so individualized. And in Oregon, Oregon State University has an office in every county. So they have offered these offices so that at least MTI with their dental vans has a spot to be. But then the idea was to take these vans out to whoever needs them. And I don't know that we've got it drilled down. I don't know that they've got it drilled down to exactly how they're identifying people yet. They're working on with like we talked about Meals on Wheels, using Meals on Wheels as one of the options to identify some homebound seniors that need access and support, and trying to work through organizations that already have the trust built with the clients and residents, so we're not having to recreate that part of the wheel. But I love the idea about the ambulance. I think that's a brilliant idea. I haven't even thought of that one. So we're still working on that, but right now, I think the key for us is just having the contract that says, yes, we're going to receive those vaccines. And I'm grateful for everyone else who's helping support that effort. I saw a note from Cambia that they're helping, and I'm just so grateful for that support. Thank you.
So there's a question about whether the vans have a fridge on board and where you can store the vaccine vials appropriately. And yes, Serena, typically that is how that's done, whether it's the EMS groups or whether it's the dental vans and such that we're hearing about now. They have to have the refrigeration in order to keep the vaccine viable. So I'm going to move on to the next question, which is whether this requirement ought to apply to home care provider agencies as well, the requirement of having representative diversity among those who are vaccinators. Will this pose a resource challenge?
Marjorie, I'll just jump in for a minute. Having had home care in my home health care in my past, this was always the aim of any home health care agency to look like the population that it serves. It's a requirement in Joint Commission. It's certainly a recommendation. So I think this just re-emphasizes to them as well how important that notion is as well. I wanted to add too, when I was with the small group discussions in our last call, you know, the vaccinators at home are different than the vaccinators that can be at a large, vaccination facility. And I remember it was very much emphasized in our small group by a number of people that these have to be fairly sound clinical people, you know, in home care and home health care. New grads necessarily would find it very difficult to function in a very independent, place. And so I just wanted to add that complexity to this, that vaccinators also have a different, need a different skill level at home, as well as being diverse, which I think is as long as you have to hire some people, hire the right people. But I just wanted to add that element of complexity. And I would also like to add, and a couple of people reached out to me on this, there's certainly, and I developed a psychiatric home health care program at one time. There are people who physically could leave, but with their state of mental health, they could not. And so I'm going to make sure that we talk about Medicaid complex, that we're also thinking about all medical situations, including those that have homebound due to some mental health issues or situations.
Sure. New notification from Outlook 2000.
Such an important point, Jane. Sorry, we're getting some feedback from someone who's not muted. Would love to hear from any others who have thoughts about the home care provider agencies here and the role that they'll play and constraints, putting too many constraints on who should be going into the home. Is that going to be a challenge?
This is Erin from Idaho again, and we have a significant issue with all of our in-home services simply because with the extra monies applied towards unemployment and a variety of other issues, it's hard for it to make sense for either the service providers or for individuals to provide care when they can do other things, or unfortunately in some cases nothing, and make more money at it. It did remind me though of one other thing that we were doing with those flyers, is we were using them in home delivered meals. And when you were just talking about the needs of people that may not be putting home delivered meals together with USDA food boxes and things like that, to create an insert that addresses people that may be having some behavioral or mental health issues, to put them at ease and say, this is what we can do as far as getting an in-home immunization, which isn't directly the question we were talking about, but it came to mind. So thank you.
No, it's a brilliant idea. It's very simple to implement, and you know, in a number of places, folks are partnering the Meals on Wheels lists with some of these, you know, the groups that are having the fire department and EMS groups going out, and they already know this is a population that is homebound, so they're just going ahead with it. But it's for those who don't have those kinds of partnerships yet, that would be a great way of letting them know, here's how you could get an in-home vaccine. I am going to suggest that we move on to our next recommendation, which focuses on scheduling and providing vaccines. So the recommendation that we're working with and that is under consideration is that state, tribal, local, and territorial departments and federal agencies should allocate vaccines as appropriate for their homebound populations. That is to say, single-dose vaccines are advantageous in areas with significant local logistical challenges, and two-dose vaccines will continue to be advantageous generally for addressing social isolation. So understanding that although it is more logistically difficult, having two vaccines provides another chance for a medical contact, a human contact for someone who's homebound, and that is valuable. And some jurisdictions have already been doing this in the face of government leaders who are more concerned about getting shots into arms. And so the question that we're posing for you all is, which should be prioritized? Who should make that decision? Is this about herd immunity, and is that more important than ensuring vaccine access to those who may be more vulnerable than in the general population? So this is a spicy one. Would love to hear your thoughts.
This is Kyle Allen. I'll chime in and get things going. I think particularly this last question about herd immunity versus ensuring those more vulnerable. When you're looking at the vaccines that now have almost 100% prevention of death and a fairly high significant prevention of hospitalization. And as you remember, in the early part of the pandemic, we were trying to make sure that we had enough hospital beds to accommodate not only those with COVID-19, but those who also may have other medical conditions. And so part of what we're dealing with too is not just the COVID-19, but also other health benefits that when you have the health system kind of clogged or bogged down with this, and the fact that you can prevent so much harm from the vaccination, then certainly vulnerable populations in a pandemic. But I would be interested in the public health specialists here. Like, you know, and I know it's a great debate, but like, we know we have limited supply, we have logistics, but if we focused at where we would do most good or prevent most harm, it has not only a primary benefit of preventing hospitalization and death, but you would also, you know, potentially unclog the system or unburden the system, so to speak. And I think also when you're talking about the homebound and that vulnerable population, you have to talk about the caregivers as well. So I think it's as a unit, so to speak, because of the caregivers and those vulnerabilities. But I'll use those as kickoff comments for people to chew on and debate.
Thanks, Kyle. So I see Mary Jo has her hand up.
Yes, I just wanted to mention for us anyway, with these dental vans, we had preferred, if it's possible, to just have the one-time dose that was not so, you know, concerning to have the freezers. But because we don't know what we're getting, we went ahead in our setup costs and got the coolers that we needed for the Pfizer, the real, you know, low temperature ones. So we're ready for whatever we get, but we would prefer having the single dose in terms of logistics, if it's possible. But then we heard from some of our groups, some of the folks that we're partnering with in the local, small rural communities, that some folks are concerned about that single dose vaccine because of how it was created. It's above my pay grade, but so we're just going to be ready for whatever we receive and be grateful for what we can distribute. So that's kind of the approach we're going to be ready for anything. That's sort of the approach we're taking at this time.
Yeah. Kathy comments that 2 visits won't address social isolation without other interventions. Well, true enough, true enough. The question is it better than nothing? And for some people, it really is almost nothing that they're getting. But is that worth the trade-off? Does your comment suggest, Kathy, that you think there's a right answer here about which vaccine should go to those who cannot leave home?
I think again, should be based more on availability. I don't see this unless, again, there's some sort of coordinated effort to get someone socially connected to say this is addressing social isolation. There just doesn't seem to be a connection with one additional visit that's really going to have any meaningful impact. Certainly someone may welcome another visitor, but then that's it. So I don't see a linkage to saying that having 2 vaccines is going to help with the problem of social isolation, particularly given how severe everything is right now for many.
Mm-hmm, mm-hmm. Kalkadan has the hand up. Go ahead.
I think that our single dose vaccination, if we do get that to be available, I think it'd be more important to focus it more towards our homeless populations, because those are populations that are going to be hard to track. And if we can vaccinate them out with 1 shot instead of trying to track them down and give the second one, that'd be more effective, because for our homebound population, we already know where they're at and their availability. So it's, for logistics wise, it's better to do the 2 shots for our homebound than utilizing our 1 shot for homebound when we have other populations that can benefit from that.
Interesting. It's not a comment that I've heard before. Others have any response to the idea that the single dose vaccine may be more appropriately used for people who aren't always exactly where you can find them? Well, if not,
Margie, I'll just add a note here.
sure.
And I know there's a lot of messaging that has to go around this. We've had this discussion in some of the groups before this, other huddles, but Dr. Fauci always says, and I think it's easy said, I guess, but take the vaccine you can get. And if some states and some jurisdictions have 2 doses, then let's use that. If some have 1, let's use that. But I love the idea, such a great point about folks that are homeless, because that would make great sense there too. So whatever we have and whatever we can use, I think that's the best one to take, if whatever's available.
This is the prep call though.
So I'm gonna suggest let's ask about herd immunity, and I feel like to some degree that this goes to the provocative question that Kyle was asking at the beginning. Is herd immunity more important than ensuring vaccine access? I'm so sorry, we're getting some noise on the line. If you could mute, please, unless you're talking. Yeah, I mean, I think the point you've made is a good one. I guess I'm asking the question, if we are going to make a recommendation around this that goes beyond, of course, use whatever's available, but this recommendation is addressing what ought to be available and what should be allocated. And so I think we're trying to be a little bit deliberate about what becomes available and with the rationale behind it. Any other thoughts on this one?
This is Kathy. I would oppose that kind of phrasing. There's already enough ageism and other ways of discounting this vulnerable population. I think we want to have we fight for person-centeredness, and I think we should be fighting for these individuals to get vaccinated and I think herd immunity is certainly important because that helps increase protection for everyone in the community. But I think we might be framing this in a way that could end up hurting the very people we want to see get vaccinated.
Great point. So I'm looking at the time and I'm realizing how quickly it has gone. I'm gonna just lift us up a little bit and look at the next huddle that's coming up. We won't have a chance to talk about any others at this time, any other recommendations, but our next huddle call is on Friday, the 26th at 12:30 Eastern time. And our featured speaker will be Robin Lipson, who is the Deputy Secretary from the Executive Office of Elder Affairs in Massachusetts. We hope all of you can join us for what will be, I'm sure, a very good presentation and discussion. For our upcoming calls in April, we actually have a new method for registering. And so I'm going to paste in the chat the link to the new registration. This is for the huddle calls that will begin on the 2nd of April. So you can use that one moving forward for the things April 2nd and beyond. Want to thank you all so much for the rich conversation today. And we will be sharing the slides and the recording with you all as soon as they are available. We want to thank you all for everything that you are doing.
And Margie, if I could just mention, next Wednesday, there will be no huddle call because we will be facilitating our webinar, national webinar at 3:00 p.m. Eastern time on this issue with a great series, a great panel of experts. So I hope you will join us for that.
Thank you all so much.